Hi, my name is Lissa Giles, and I'm here to give you a brief presentation on the recognition and treatment of multisystem inflammatory syndrome in children. The goals and objectives of this lesson are to give you an increased level of preparedness should you need to care for a patient with MIS-C. In the lesson, you'll learn how to differentiate between MIS-C and acute COVID-19 infection, identify the signs of shock in MIS-C, and understand the recommended treatment that's based on the American Academy of Pediatrics interim guidance. First, let's test your knowledge so we can measure where you're at right now. I'm going to give you a self-assessment test. Read each statement and rate yourself on a scale of 1 to 5, where 1 is strongly disagree and 5 is strongly agree. Go ahead and pause the video now so you can take the self-assessment test. At the end of the test, add up your score and hold on to that number till the end of the video. So let's define MIS-C. What is it? MIS-C is defined as someone who's less than 21 years old and presents with fever, evidence of inflammation on their labs, severe illness requiring hospitalization, and multisystem involvement, which is 2 or more organ systems. They've also either had a known exposure or confirmed diagnosis of COVID-19 within the last 4 weeks. And there's no other plausible diagnosis for their syndrome. So what do you need to know as an ED nurse about MIS-C? ED nurses, especially those who are in triage, are key to identifying MIS-C early. If we can intervene early, we can hopefully improve outcomes for these patients. So getting a detailed history from parents or caregivers is a very important step in identifying MIS-C. Please do not ignore or brush parents off when they tell you there's something wrong with their child. Children come in with subtle signs of illness. We might not see changes in their vital signs right away, but there's early indications in behavior, activity level, color, and appearance that might show that this child is going to deteriorate later. So please listen to the parents when they give you their history. It's important to know when they were sick. Did they have COVID, or did they have an exposure to someone at school 3 or 4 weeks ago, and now they're presenting with this fever and tachycardia, tachypnea, or altered mental status. These are the things that we need to know, so it's very important to get that history from parents. Let's look at the epidemiology. So MIS-C is a rare but serious condition. It's occurring in less than 1% of children who've had COVID. Most of the cases are occurring in children who are older or adolescent age, with a median age of about 8 to 11 years old. And the studies have shown that over 70% of the children with MIS-C were otherwise healthy. If there were comorbidities, the most common ones were asthma and obesity. Studies have also shown that Black and Hispanic children have been disproportionately affected by MIS-C. These are some key differences between MIS-C and Kawasaki's. MIS-C has been related to Kawasaki's disease because some of the signs and symptoms are similar. However, Kawasaki's usually affects those of Asian descent and typically affects infants and younger children. It's also important to note that with MIS-C, it's a post-infectious complication from COVID. So it's going to manifest 3 or 4 weeks after they've had the acute infection. Let's discuss the pathophysiology. It's not well understood because it's new and there's not that many studies, but it's theorized that this syndrome develops because there's an abnormal response to the virus, which leads to an exaggerated immune response and systemic inflammation. This inflammation can cause myocardial injury. It can cause thrombolytic complications, acute kidney injury, respiratory failure. Respiratory failure with MIS-C is different than respiratory failure from COVID. That's going to be talked about in a minute. Liver failure, neurologic impairment, similar to meningitis. They might be altered, confused, lethargic. Gastrointestinal inflammation, colitis, questionable hepatitis, even questionable appendicitis. So what can you expect to see in a child with MIS-C? You're going to see fever, rash, conjunctivitis, red, swollen lips or strawberry tongue, swollen hands and feet, headaches, lethargy, confusion, GI involvement, which might be abdominal pain, vomiting, or diarrhea, and last case scenario, shock. This is what we want to avoid. So how can we tell the difference between acute COVID and MIS-C? Well, MIS-C, you're going to see fever and inflammatory systems that come after the illness, after they've had COVID. With acute COVID, it's typically going to occur in children with underlying health problems. In most cases of MIS-C, the children were otherwise healthy. With acute COVID, the respiratory involvement is more consistent with the pneumonia, ARDS, like we see in the adult patients. With MIS-C, your respiratory involvement is going to be secondary to shock or CHF. You're also going to have GI symptoms are more prominent in MIS-C versus acute COVID. With acute COVID, you're not going to have those mucocutaneous findings like you do in MIS-C. Mucocutaneous findings are more common in MIS-C. Also, the inflammatory markers in MIS-C are going to be more elevated compared to someone with COVID. This also indicates how severe their MIS-C illness is. With higher markers, you have more severe illness. So let's talk about shock. MIS-C, it affects the heart. Typically, you're going to see cardiogenic shock. So how is your patient looking? Do they have signs of poor perfusion? Are they compensated or uncompensated? These are things that you need to look for. Are they tachy, tachypnic, hypotensive, altered mentation, lethargic, decreased peripheral pulses compared to their central pulses, poor skin signs with delayed cap refill or mottling? Cardiogenic shock, it can cause arrhythmias, it can cause left ventricular dysfunction. So these are very important things that you need to be aware of when you're looking at your patient. Now let's look at treatment. We want to do supportive care, fluid resuscitation, respiratory support, maybe ECMO if it's very bad. Pharmacological care looks like antibiotics, inotropes for that cardiogenic shock, steroids, biologics, IVIG. This all helps with immunotherapy, and it's actually been shown to improve their symptoms and help them recover their cardiac function. There also might be an order for low-dose aspirin to help with thrombosis, unless it's contraindicated in the event of active bleeding or a platelet count less than 100,000. Follow-up care might not be that relevant to us in the ED, but it's important to note because we might be seeing these patients come back after they've recovered from their MIS-C. They're going to have close cardiology follow-up. They're going to have activity restrictions and need to be cleared by their cardiologist before they can resume activities. And they're probably going to be followed by rheumatology if they've had any of the steroid treatments or IVIG. All right, let's see if you improved and if you have more knowledge now. Let's take the self-assessment again. Record your results, add up your score, and compare it to the one from before. Go ahead and pause the video now so you can take the test. And finally, please let me know how I did and take my survey. If you scan the QR code below, it'll take you to my survey where you can let me know how you did. Was my video and teaching effective? Do you feel like this new knowledge is going to impact your practice? I hope it does. I hope that you will take this new knowledge, and when you're out there taking care of patients, you can recognize these things early and help improve outcomes among our pediatric patients. In case you want to know where I got my information, here's my links and references. They had great information from all these sites. I hope that this makes a difference in your practice. I hope that you learned. Thanks for watching.